Second question is, how can we improve outreach to underserved populations who are poorly represented in cancer research and treatment?
To offer free clinics in them. And when I think of these people, these are people who are just not in the grid. They don't have any kind of medical record or insurance, or that just don't even have any idea what clinical trials are. And I think the disadvantage to that is, of course, the people who do know about clinical trials, they tend to be more educated, they tend to be more high pay, and they'll go for clinical trials, whereas so they will live a different lifestyle from people who may not, maybe underserved, for example. Underserved populations might eat differently, or they might have different exercise habits, for example, and so therefore your cancer treatment and research is might be biased towards people who are more educated and just know more about clinical trials. And I think from what I've seen, a good way to reach out to the underserved is to go through nonprofit organizations. This liaisons through these nonprofit organizations that really reach out to the underserved, that really, to some degree, keep track of these underserved populations who otherwise wouldn't be on, wouldn't have any representation anywhere. So I think this more collaboration with nonprofit organizations would help to outreach more.
Do you screen the patients or talk to them about cancer when you're doing evaluations?
Well, that balance, yeah. So.
Do they talk about them, or are they more other issues, health issues for the most part?
For the most part, it's more just a clinic, so we just do the general silk the write-ups.
One of the important ways of reaching out to underserved populations is really awareness. And I'm just going to tell you about a little study that we've just completed at TIJA. And the underserved population is not in the United States, it's actually in Egypt. And I made collaboration with pathologists in Egypt by which to get tissue to study, to do just a simple molecular characterization of breast cancer specimens. So this is the breast cancer side of me. And the conclusion to the study was, so their outcome is much, much poorer. So women with breast cancer in Egypt do much, much worse than women in North America or Europe. And the reason isn't biological. That was the conclusion of the study. The reason was purely, is going to be purely due to lack of awareness, lack of understanding, stigma, and lack of proper treatment. So I think one of the most important ways of reaching out to underserved populations is awareness. So it's programs like these. So I just wanted to shed light on how important these forums and programs really are.
Yeah, this is my favorite topic. Let me go through a list of who's underserved. Elderly. Everybody goes to racial ethnic groups when you say underserved, by the way. And that's very true, but let me go through the list. Elderly, women, children, adolescents, low income, those who live in rural areas. I'm sure if you know where Kingman is, and you know where Greenlee County is, and Duncan, and these places, they don't get on clinical trials out there. And folks with special needs. So disabled, chronically ill, folks with comorbidities, particularly substance abusers. And so you can see that that's a very, very, very large list. One of the reasons that a lot of this does come back to racial ethnic groups is because of the clear disparity in, you can start at death all the way down to disability caused by specific diseases. African Americans tend to have the worst outcomes for just about every cancer, generally. Asian Americans, oddly enough, tend to have the least in terms of overall mortality. But the issue is that these very big categories create problems when it comes to specific priority setting, because within any group that you look at, there are folks who basically will have higher mortality or will present with pretty serious illness that needs to be studied or needs to be intervened with. So I think that the recent push that you see to try to enroll more folks that are underrepresented in clinical trials has to do mainly with epidemiology. You know, these disparities that are out here, that the morbidity and mortality, the death and disease that you see related, in this case specific to cancer, but you can pretty much go down the list in terms of disease. Native Americans in the state, for example, we have 22 reservations on this state. Everybody knows what they're pretty much being afflicted by, right? What are they being afflicted by disease-wise?
Diabetes.
Yeah, but they also have very high kidney cancer, higher than the national average, certainly. But nobody's really looking at that. So I think those are some of the complexities in terms of who's not, who's underrepresented. Just from my perspective, the critical issues in terms of involving these folks, it's complex in the same way, that it's complex just enrolling anybody into a clinical trial. But involving children, you're not dealing with the children, you're dealing with the parents who are going to be consenting for those children and so on. So every group that you think of, there's additional complexities. The one term that I particularly despise for that's used with underrepresented populations is that they're hard to reach. And that's used quite often in terms of clinical trial recruitment. It's not that they're hard to reach, it's basically that our infrastructures aren't set up to reach out to those populations. So I see that a lot of the reason for the underrepresented, for me, it starts with really the study questions, the researchers who are doing the research in the first place. It always goes back to that, as far as I'm concerned. If there aren't researchers that are interested in a given population with a given disease, it's not going to be studied. There aren't going to be study sections who are reviewing those kinds of grants and so on and so forth. My background is in primary health promotion. It's shifting over from public health practice. I did tobacco control for 10 years. I think I did more to prevent cancer, trying to keep people from ever beginning to use tobacco and helping people quit, than a lot of folks doing cancer research have ever done, quite frankly. And that's primary prevention, but primary prevention is not on the radar screen when it comes to cancer generally. I mean, secondary prevention certainly is, which is more like chemo and so on. But anyway, not to diverge too much. So that research question, and is it going to be inclusive of certain populations? People that are interested in doing research in rural areas with children that might have leukemia. There was an interesting write-up down in Tucson about the high leukemia rates down in Sierra Vista. Nobody can really figure out what it is. There are all kinds of ideas about that. But there are a whole lot of folks looking at that. So that question, I think, is very important. The recruitment, how you recruit, and really just the opportunity, like I said, at the patient level and at the researcher. Victor alluded to the issue of language. From my perspective, if you're going to put together a clinical trial for a given population, you need to be able to communicate with them. And I'm not just talking about English, Spanish, English, Greek, or other languages. I'm basically just talking about being able to communicate with them. Adolescents speak a different language. Children speak a different language. Low-income folks that are homeless, the psychosis that has happened to them, they speak a different language totally, and they have very different sensitivities. So I think those are like the real complexities in trying to recruit.
Yeah, and Jesse and I sit on several committees that look at these things constantly, so this is definitely something that we're passionate about. But one thing that I do...